the topic mainly discuss about how our blood glucose is regulated within a short range. What is the range? 20 to 110, more precisely less than 100 in fasting state. In postprandial, same. In postprandial, same. It may go up to 140, but it may go as low as 70. Right? What is the level of postprandial? Postprandial. 2 hours. Postprandial means 2 hours. It should be exactly same as fasting. The postprandial level should be exactly same as fasting. That is normal. But in some cases it may go up to 140, up to, not means 140 is normal. If you get a fasting sample, say around 75, and if you get a postprandial 72 or 70, that means it is normal. Okay? As the age of the patient increases, this postprandial level also increases. Why? Due to resistivity, insulin resistance. If you maintain your health properly, it will not increase. If you cannot, it will increase. Then, to what extent it can increase, so as to we can call the patient is not normal anymore and he is having a disease. More than 200. In any case, be it random, be it postprandial, be it fasting, if it is more than 200, sure shot the patient is having diabetes. But in fasting, the values are little different than 200. It is 120, 124. So, if it is more than 124, then we call it diabetes. Now, when I say fasting is below 100, and some lab they will show 110, it varies due to difference in measuring tool, the method by which blood glucose is being estimated. Okay? If you continue with the same method throughout the world, you will get less than 100. And it must not go below 70. If it goes below 60, then we call it hypoglycemia. Which one is more dangerous? Hypoglycemia. That's why we have only one hypoglycemic hormone against 7 hyperglycemic hormone. Right? Now see, after 2 hours it should come to same level. This is ideal. At your age you will get these kind of results. But if you get more, that means what? Are you diabetic? Say up to 120, 130, 140, no. Why? Because most of the time we do not measure and eat. We do not measure and eat. When you say after taking food, how much food is it mentioned here? So how much food is sufficient for you? How much food is sufficient for me? How much information for her? No one knows. Why? Because our body weights are different. Correct? So how much sugar could be given? For that also one calculation is there. For that also one calculation is there. 1 gram per kg body weight not exceeding 70. 1 gram per kg body weight. That means if your body weight is 65 grams of glucose should be taken as a food. If your body weight is 72, 70. If your body is 150 kilo, 70. Correct? I repeat, 1 gram per kg body weight not exceeding 70. 1 gram per kg body weight not exceeding 70. If the patient is a child, his body weight is 40 kilo. Should we give him 70 grams? No, 40 grams. Correct? So these are the things. So when we do not measure while eating, so we must have a wide range. That's why in postprandial sugar, it is given a wide range. Yeah? Did this question ever arise in your mind? That in fasting it is 70 to 110 and PP you are telling it should be same, but we are giving up to 140. PP normal is up to 140, up to. Lower level is not mentioned. Why? Can it become less than 70 after 2 hours? This class is very, very important. Throughout the year, from this class only you will be asked questions. Those who are missing it, they will miss it forever. Can a normal patient show postprandial glucose level less than 70, say 65 or 62? Yes. It is called hyper-insulinic dip. Hyper-insulinic dip. What is that? Maybe the insulin secreting system of that individual is very efficient. The moment the blood glucose starts rising, insulin is secreted and it acts on the tissue and glucose is immediately taken up by the respiratory tissues. So the speed at which glucose is taken up is much higher than the supply of the glucose. So it goes below for some moment. Next half an hour if you take, again it will come back to 70. Correct? So it is called hyper-insulinic dip. Hyper efficiency of insulin. So all these are normal characters. Correct? Now when we say blood glucose homeostasis, we always discuss about the normal scenario. Means blood glucose regulation means maintenance of a blood glucose between a level throughout the day. Right? If you are starving, then it should go beyond that. If you are eating more, it should go beyond that. Correct? So there are two conditions. One is physiological condition, another is pathological condition. In physiological condition, blood glucose level is maintained by different methods, by maneuvering different metabolic cycles, by different hormones, which our HOD sir has already discussed. I will discuss the second part. What happens in case of pathological condition when the derailment of blood glucose level is due to pathological reason? কি বললাম? যখন blood glucose level pathological কারণে চেঞ্জ হয় তখন কি ঘটতে পারে এবং কিভাবে আমরা সেটাকে আবার নরমালে আনতে পারি। তার মানে কি হচ্ছে, একটা ডিজিজ হচ্ছে এবং সেটাকে আমরা ডায়াগনোসিস করব, তার মানে তার সিমটমস থাকবে, আর কি থাকবে, আই হ্যাভ টু ট্রিটমেন্ট থাকবে, তাহলে চয়েস অফ ড্রাগ থাকবে, তাই না? রুট টু চয়েস অফ ড্রাগ থাকবে, কি হবে আমরা এন রুট, কি হবে আমরা কোন ড্রাগটা চয়েস করবো সেটা থাকবে, তাই না? এইগুলি আমরা দেখব। সুতরাং এই জায়গাগুলো আমরা এক্সিট করব। প্যাথোলজিক্যাল রিজনে ঢোকার আগে আমরা এই কন্ডিশনটা আসি, গ্লাইকোসুরিয়া। ঠিক আছে, গ্লাইকোসুরিয়া বলতে আমরা কি বুঝি? গ্লুকোসুরিয়া Glycosuria means excretion of carbohydrate, glucosuria means excretion of glucose. Is our urine totally free from glucose? Correct? Normally it is less than 150 milligram per day. If it goes beyond 0.5 gram per day, then we can detect 0.5 gram. Now tell me, what is the different values of urine formation of our body? Draw it. On average, usually we produce around 1.5 liter of urine per day, depending on the size, depending on the normally. It cannot go beyond 500. It cannot go beyond 500. Right? In either cases, too extreme, their disease condition or altered condition. Normally, it should be like this. 1000 ml, 1.2 liter, 1.3 liter, 1.4 liter, 1.5 liter, 1.6 liter, fine. Now, if I say 0.5 gram per day means how much? So, this much will contain, okay, 0.5 gram. Now, you have done Benedict test in practical. There you have found there are different colors. What are those? Green when it is correct. Then remember this, like the religious dogma. Don't ever forget. Right? Different causes of glucosuria. Just quickly write down, because for glucosuria I don't want to spend more time, because this topic will be again taken in your SGD. Okay. What are those? Diabetes mellitus means uncontrolled blood glucose level, uncontrolled or untreated diabetes mellitus. Then adrenaline surge, when it happens? When you are in stress, like before NEET results, like before the final paper, like before the coming 14th February, there is also stress. Like before, when you are caught red-handed with a burning cigarette by your dad, or drinking by your mom. If father sees drinking, won't mind. If mother sees drinking, gone. If mother sees smoking, won't mind. If father sees smoking, gone. Why, I don't know. Fine. So, these kind of stressful condition secretes adrenaline, which increases blood glucose level, and it may shoot more than 180 milligram %. That is the renal threshold for blood glucose level, beyond which it appears in urine. Renal threshold means Renal threshold of a substance is a concentration of a substance in the blood beyond which it appears in urine. Renal threshold of a substance is a concentration of the substance in blood beyond which it appears in urine. Correct? Sometimes this renal threshold may alter. Sugar may appear even though the blood glucose level is much below than 180. Correct? Okay. Then third comes elementary glycosuria. What is this? For whole day you are busy in the dance practice, okay, till late night, from early morning, and didn't have anything. Night around 1 o'clock, your roommate brought 2 packets of biryani. You ate a lot. Because whole day you were hungry. What will happen? That night you have to get up frequently for correct? Why? Because after a glucose deprivation, you are taking a large meal, that will increase elementary glycosuria. Next, causes for renal is kidney disorders. Yes, I mentioned, na? This nephritis, nephrosis. Some cases will show glucosuria also, some cases, not all, but in most of the cases, nephrosis will show proteinuria. Proteinuria is more common in nephrosis than glucosuria. Then fluorogen glucosuria. What is fluorogen? It's a chemical, it's a drug. If it is applied, it is given to an animal, an organism, a subject, then it cannot reabsorb glucose from the tubular secretion. So it appears. And when glucose appears in the urine, it draws water along with it. So more and more water is drained out from the body. Pregnancy-induced glucosuria. In case of pregnancy-induced diabetes mellitus, which comes with pregnancy and goes away with pregnancy. But during pregnancy, having this diabetes it may be dangerous for the fetus or baby. We should take care of it. So in pregnancy, many times we receive a test called oral glucose tolerance test. Young female during their pregnancy give this blood for oral glucose tolerance test. There a patient is asked to consume certain amount of glucose. Remember that 1 gram, what I mentioned per kg body weight, is for anhydrous glucose, but the glucose available in the market is not anhydrous. It is either hexahedral, monohedral or docahedral, means 10 molecules of water can also be there. You have to see which company, what product you are buying, and accordingly you have to calculate. Okay, not going to that complication now. For the timing, you remember 1 gram per kg body weight should be given, not exceeding 70. Now, congenital glucosuria, some renal disease the person born with. It might show diabetes in a sense, benign glucosuria. Nothing is wrong with the kidney, but it is showing glucosuria. Patient is normal, having normal life, but it is showing glucosuria. Unknown cause. Okay? Then pregnancy-induced nephritis, nephrosis, small cases, small portion of percentage of cases show glucosuria as well, along with proteinuria. Fluorogen kind of drugs which inhibit which drug inhibit glucose reabsorption? Dapagliflozin. It inhibits SGLT2 inhibitor. SGLT2 inhibitor, dapagliflozin kind of drugs inhibit SGLT2, which is located in the renal tubule. So, renal tubule cannot reabsorb glucose and glucose appears in the urine, causing polyuria, common metabolic disorder in the world. The diabetes mellitus has got following syndromes. What is that? From Munna Bhai MBBS, we know the 3P. Munna Bhai MBBS, have you seen movie? What are 3 Ps? 3 Ps are given. Polyphagia, polyuria and polydipsia. Polyphagia means what? You feel more hungry, you eat more. Polyuria means you frequently pass urine, and polydipsia means since you are frequently passing urine, you get more thirsty, so you drink more water, so you pass more urine. But every time you pass urine, your urine contains glucose, and that is the reason you pass more frequently urine. Then what else? The blood glucose level is always high, and even though you are eating so much, so this is probably the first thing or this thing the patient will complain of. Patient might come to you with either this complaint, sudden loss of weight, or this complaint, not having good sleep in the night. What is the reason? I don't know. Then you should ask how many times you get up for passing urine? 2-3 times. Do you feel thirsty that time? Yes. Get your blood tested for glucose. That's all. Fine. So these are the common symptoms the patient will complain with. Causes and types. Remember, these types are old now. Nowadays it has changed. By the time you reach final year, probably this classification will be obsolete. Okay. But for the time being, we will concentrate on this classification only. What is the classification? Type 1 IDDM and type 2 NIDDM. Remember, type 2 will occur only in case of adult. Like this, you remember. If the case is minor, not adult, then it might be type 1. Not in all cases, but it might be type 1. What is a type 2 means? See, if you give insulin also no issues, because why? Insulin cannot act. Insulin resistance is very high. The cells are covered with fat. There, the insulin receptors cannot surface out. সেলের চারপাশে ফ্যাটের একটা লেয়ার পড়ে, যেখান থেকে ইনসুলিন রিসেপ্টরগুলো ফুটে বেরোতে পারে না। তারপরে কি হয়? টিস্যুগুলো ইনসুলিন এগেন্সে কাজ করতে পারে না। যে গ্লুকোজ ঢুকবে সেটা হতে পারে না, কারণ ইনসুলিনটা রিসেপ্টর খুঁজেই পায় না, ফ্যাটের মধ্যে লুকিয়ে থাকে। ইনসুলিনটা ফ্যাটের মধ্যে লুকিয়ে থাকে, যেটা টিস্যুকে কাভার করে থাকে। এবার যেই টিস্যুর কাভার থেকে তুমি ফ্যাট সরিয়ে দেবে, সঙ্গে সঙ্গে আবার ইনসুলিন কাজ করবে। তাহলে উপায় কি? এক্সারসাইজ করা, ঘাম ঝরানো, তাই তো, যাতে ইন্টারনাল অর্গানের ফ্যাটগুলো কমে যায়। হ্যাঁ, ইন্টারনাল অর্গানের ফ্যাট কখন জমা হয়? যখন আমরা sedentary লাইফস্টাইল লিড করি। We do not walk, only eat and sit and sleep. হ্যাঁ, তখন হয়, তাকে বলে sedentary লাইফস্টাইল। তাহলে অ্যাক্টিভ লাইফস্টাইলে ফিরতে হলে ইটস এ লাইফস্টাইল ডিসঅর্ডার, most of the cases, type 2. Type 1 is something different completely. In type 1, you might get the amount of insulin present in the blood is normal, but patient is diabetic. Why? Because insulin is being produced, but it is somehow inactive. It is somehow inactive, so it cannot work. Right? So if you give normal insulin, it will act, patient will be normal, fine. But if the disease is due to receptor, then it becomes, if something is wrong with the insulin, if something is wrong with the insulin receptor, bolo? Don't forget, something is wrong with insulin, something is wrong with insulin receptor type 2. Now, in most of the cases, many of the cases, not most, many of the cases, it was found that the poor insulin fellow is being secreted normal. But other hormones, due to some awkward reason, means ectopic production, tumor, cancer kind of reason, are being produced more. In many cases, it has been found that insulin is normal, insulin is functional, insulin is being broken down normally, everything is fine, but glucose is high. Then they found glucagon is being secreted more. In some cases, they found there is a tumor in the adrenal gland which is secreting more adrenaline. Okay. There is a disease. What is the disease? Carcinoid syndrome. Okay. Now, metabolic changes. Metabolic changes. The carbohydrate metabolism is disturbed. The glucose uptake by tissues which are dependent on insulin, what are those? Adipose tissue and muscle tissue. They are deprived. So, decreased glycogenesis. Why? Because cell is always starving. No glycogenesis. Why? Because insulin is less. Insulin is anabolic hormone. In absence of insulin, no anabolic pathway will take place. So, no glycogenesis, no lipogenesis, but yes, lipolysis. So, what will happen? Free cholesterol level will increase, triglyceride level will increase, and fat will break down more. Why? Because insulin is absent. Because insulin is absent. Then increased glycogenolysis and gluconeogenesis. So, when glucose cannot be taken up by the tissue and tissue feels like the patient is starving, it will break down protein to produce glucose. So, there will be protein wasting, you will lose further weight, correct, and you will become weak. Lipid metabolism. Increased lipolysis increases plasma free fatty acid. Lipolysis means what? Breakdown of triglyceride. Breakdown of triglyceride. Triglyceride means 3 molecules of free fatty acid, 1 molecule of glycerol, like this. It is joined with 3 fingers. So, they are shredded off, cleaved. So, free fatty is more. Increased ketogenesis, increased free fatty acid, low blood glucose triggers ketogenesis. The liver starts producing ketone body, feeling or fearing that patient is undergoing starvation. It will break down all the free fatty acid to acetyl coenzyme A, and from acetyl coenzyme it will make more and more ketone body. Now, the brain, which was preferring glucose throughout this time, will act like an opportunist. It will change its preference towards ketone body, and the muscle also will start using that same. Remember, liver can produce ketone body but cannot utilize. Why? Because it does not have to. Why? Because entry of glucose does not depend on into liver, does not depend on insulin. So, it is devoid of presence of insulin, irrespective of presence of insulin, glucose will enter. So, liver does not require to utilize anything other than glucose. Clear? Fine. So, increased ketogenesis, which causes ketoacidosis. Some amount of ketone body will be excreted through urine, causing a condition called ketonuria. But if the production is very high, then it will surplus, it will exceed the limit to be excreted through urine. So then ketone bodies will start accumulating in the blood. Now ketone bodies being acid in nature, what are the name of the ketone bodies? Acetate, beta and acetone. Forget about acetone. Acetate and beta both are acids. So presence of this acid will cause acid-base disorder, acidosis, leading to ketoacidosis. Correct? This third protein metabolism, very easy. Gluconeogenesis is high. At what cost? Protein. Muscle protein will be broken down. Now, muscle protein can be protected if there was insulin, but there is no insulin here. That is the cause. So, in absence of insulin, protein breakdown cannot be prevented. In absence of insulin, protein breakdown cannot be prevented. So, breakdown will be more, so protein wasting will be more. And the glucogenic amino acids will lead to formation of glucose, which will supply to the blood. Ketogenic will lead to formation of ketone bodies, and both glucogenic and ketogenic will lead to both. Name the ketogenic amino acid. Leucine. Name both glucogenic and ketogenic amino acid. PILTT. P for? I for? L for? Lysine. T for? Tryptophan. Second T for? Tyrosine. Tyrosine. Okay? Remember these like your as if you use fingertips. Yeah, you can't afford to forget this. This is the essence of this subject. If you are very strong in these parts, believe me, it will help you a lot in understanding any disease condition. Any disease condition. Any disease condition is explained by only one subject. You must be strong in this. I am not asking you to get 100 out of 100 examination, but your understanding should be good. You should versed with the whole syllabus. Know the subject. You may not score high, but know the subject. Be a little serious with the subject. Fine. Water and electrolyte balance. What happens? If there is more and more excretion of water, then water deficit will be there, then increased loss of sodium and potassium in urine, because more and more urine means more and more electrolyte is being lost. So you have to take more and more electrolyte. You are eating means what? You are replenishing the electrolytes. You are eating more, What you are eating? What do the diabetic people like most? I give you option. Blanched vegetable, like broccoli, boiled broccoli. I tell you what they like most. Boiled chicken, French fry. Which one? Which one you think the diabetic person will like most? French fry, because it is fry. They like more fried food. If I put rasgulla also beside, they will choose. They will take more and more fry. Now already your plasma is laden with this. Then again you are taking French fry. What you are producing more? This. What will happen? Angina pectoris. Heart will stop working. Fine. Now, time is over. Oh my God. Complications of DM. Two divisions, macrovascular and microvascular. Macrovascular complication, just write down. And microvascular complications. Macrovascular means all the big blood vessels will be involved. Small. Microvascular means small. See, almost, just keep on writing, don't stop. These are more informative than explanatory. These are more informative than explanatory. You have to remember these names. Macrovascular are of 4 types. কি আছে? বলো? হ্যাঁ, এটা ভুলবে না, এটা পরপর লেখো, উপর নিচে লেখো। Like up, মানে from 1, 2, 3, 4 you write. Macrovascular complications. Number 1. Number 2. Why? Because of hardening of the wall of the blood vessels. High BP. And moreover, you are taking more and more sugar, sodium. So hypernatremia. Myocardial infarction due to this renal failure. Correct. Why? Because of this. Atherosclerosis is not only occurring in the heart, in every organ. All the organs are affected. Correct? Now we come to microvascular. What is that? Diabetic retinopathy and diabetic neuropathy. These two. Don't write all these things in red color, write in the blue color. What is the color of diabetes? What is the color of diabetes? Stand up. Dara. What is the color of our jacket? This is the color of diabetes. On World Diabetes Day, the big buildings of the cities are lighted by blue light to increase awareness. Sit down. So sorbital pathway হচ্ছে গিয়ে কি না সেটা হচ্ছে যে একটা alcohol which is a common alcohol for both glucose and fructose. If it is from galactose, then the name of the alcohol will be changed. But if it is from the glucose, the name of the alcohol is same. Sorbital. So the sorbital production and breakdown maintains a balance. Where? In the lens. Lens of the eye, not this lens. The natural lens. Through which we are seeing. Now it is transparent. That's why we can see. When this production of glucose and drainage of sorbital, this balance is disturbed. When blood glucose level is very high, then the glucose level in other tissues also somewhat increased. So the amount of glucose present in the lens also will increase. But the lens is unable to cope up with that much amount of sorbital. So the sorbital, small amount of sorbital will start accumulation. Suppose 10 molecules of glucose is being converted to sorbital, but only 8 molecules of sorbital can be excreted or converted back to fructose or something like that. Okay, or metabolized. But every time 2 molecules are being accumulated. So when this accumulated portion of the sorbital will increase a lot, what will happen? The pouch will become swollen. What is the name of the pouch? Lens. The lens will become swollen. Why? Because it will draw water. It will become swollen Now it was like this, now it has become like this, your vision will be affected, and there, due to presence of high glucose, small bacterial infection will take place, which will cause infection and which will cause what? Opacity of the lens. The lens will become opaque বা অস্বচ্ছ, তাই তো? So the opacity of the lens is due to bacterial infection, and that is triggered by the presence of glucose. So these are micro level. Yeah. Neuropathy. Neuropathy is very complicated. Usually, patients come up with complaints like whenever I am walking, I am feeling like as if I am walking on clouds. Walking on clouds. Or the patient will come and say, my hands tremors a lot while writing. But this week I failed to match my signature in the bank passbook. পাসবুকের সিগনেচার মিলছে না, কারণ কি? হাত কাঁপছে। বা ডাক্তারবাবু চায়ের কাপ হাত থেকে পড়ে যাচ্ছে, প্লেট পড়ে যাচ্ছে, গরম চা খেয়ে মুখ পুড়ে গেল। false feeling of hot and cold. যেটা গরম, কম গরম মনে হচ্ছে, আমি খেয়ে নিলাম, মুখটা পুড়ে গেল। কাপটা ধরে আছি, কখন হাত থেকে পড়ে গেল। ওই যে আমি এটাকে ধরে আছি তো, এখন এটা যদি ওজন 5 কেজি হয়, তাহলে আমার ফোর্সটা অটোমেটিক বেড়ে যাবে। যদি এটা ওজন 2 গ্রাম হয়, তাহলে ফোর্সটা আরো কমে যাবে। এটা কে ঠিক করে? আমি দেখে ঠিক করি না, অটোমেটিক্যালি হাত দিয়ে যখন তুলি তখন ঠিক হয়ে যায়, তাই তো? অটোমেটিক্যালি ফিল করি। এই প্রেশার যে কাজ করছে, এটা কি কাজ করছে? ব্যারোমেট্রিক ব্যারোরিসেপ্টার্স, তাই তো? প্রেশার কাজ করছে নার্ভে। সেই নার্ভের যে স্মল এন্ডিংগুলো, এগুলি অকেজ হয়ে যায়, নাম্ব। তার ফলে কি হয়? এটার ওজন হয়তো 5 গ্রাম, কিন্তু আমি তোলার সময় মনে হবে ওটা 1 গ্রাম, তুলতে পারবো না। বা যদি আরো বেশি হয়, তাহলে ওটা মনে করো চায়ের কাপ আমি ধরে আছি, চাটা খেলাম তো, খাওয়ার পর যখন রাখলাম, চায়ের পরিমাণটা কমে গেল, কাপটা পড়ে গেল। কেন? ওই যে চেঞ্জ ইন দ্য ওয়েট, এটা হাত আর ফিল করতে পারছে না। প্রথমবার ধরার সময় ধরেছিলাম, পরের বার ধরার সময় হালকা হয়ে গেছে, পড়ে গেল। আরে হ্যাঁ না, বুঝে গেল ব্যাপারটা? এই ধরনের যখন কমপ্লেন থাকবে পেশেন্টের, তখন আমরা বলবো ইট ইজ নিউরোপ্যাথি। It is neuropathy. Now, if the person is very stubborn and does not come to any doctor and maintains his lifestyle as he wants or he prefers to, what will happen? Very soon, how much blood sugar it can that time he might have? More than 600. More than 450 only, it is alarming. More than 600 means anytime anything can happen. Now we come to diagnosis. Write down. Diagnosis. Write down this point. Just read this one and write what I say. Don't write this one. 3 things you write. Blood glucose more than 126 milligram percent in fasting. Lake. Diagnostic criteria for diabetes lake. ওটা দেখে দেখে লিখিস না, যেটা বলছিস লেখ। More than 126 milligram percent in fasting, more than 200 milligram percent in random and PP, more than 6.5% HbA1c, 6.5% HbA1c. 6.5 HbA1c. এই তিনটে হচ্ছে WHO প্রেসক্রাইবড ক্রাইটেরিয়া ফর ডায়াবেটিস মেলিটাস, বাকি কিছু না। এই তিনটে আছে কিনা খুঁজে বার করো, তাই না? এরপর অনেক কিছু আছে। What are the other parameters we can measure to differentiate type 1 and type 2? How to differentiate type 1 and type 2? We can measure fasting insulin, we can measure C-peptide. What is C-peptide? The connecting peptide between A chain and B chain when it is in pre-pro form. Correct? Don't ask me what is a pre-pro form, because it is already taught. Protein. That's all. So this one also I will escape, I will not take. That's all. Treatment I will not tell. Ja. Last slide did last slide ki bolche. So now with this we come to the end of carbohydrate metabolism. If you still have any queries, questions regarding any of the chapter, do go through it now and then let us know what is the problem, what you don't understand.